Day to the faculty of Maryville School of Nursing and fellow students. My name is Arpita Patel. This is my presentation on my scholarly project titled Implementing a Quality Improvement Project to Increase Anti-Diabetic Medication Treatment Compliance and Achievement of a Hemoglobin A1C level target ranges with patients with type 2 diabetes. This presentation is the partial fulfillment of the requirements for the Doctorate of Nursing degree at Maryville University. Diabetes is a disease that is affecting millions of people around the world, and millions of people are not even aware they have the disease. By 2030, almost 500 million people will be diagnosed with diabetes. Diabetes is the seventh leading cause of death, according to the Center for Disease Control and Prevention, and it is a disease that needs to be better addressed, and interventions need to be placed according to factors that are being faced in aiding patients in controlling their blood sugars. The rising cost of prescription drugs has become toxic for most Americans. The out-of-pocket cost of prescription drugs has increased in the past year and will continue to rise. Despite medication affordability being the main cause of non-compliance, there are other factors that patients face that cannot be overlooked and which cause patients to be less compliant with their medication treatment plan. Such psychosocial factors such as depression and anxiety, lack of knowledge of the disease and the outcome of it not being treated, lack of knowledge of dietary changes needed to control their blood sugars, education on the uses and side effects of the medication prescribed to the patients, the need of lifestyle changes such as more physical activity and exercising needs to be incorporated in daily life, which leads to better control of a patient's disease. The purpose of this scholarly project was to implement holistic care bundle interventions such as medication assistance with providing medication information, clarifying the purpose of taking medication and its side effects, providing education on lifestyle changes that includes having a healthy diet, encouragement of exercising, and addressing changes of unhealthy habits such as smoking, alcohol, and drug use, encouraging eyes and skin dental checkup is a must, identifying psychosocial factors such as emotional factors, psychiatric illness, and giving necessary referrals out for treatment is the overall goal of this project. With implementing these interventions on type 2 diabetic patients who are not compliant in taking their anti-diabetic medication and addressing the affecting factors, our aim is to lower their hemoglobin A1C level equal to or below 7. My peacock question for the project is, in patients with type 2 diabetes who are non-compliant with their anti-diabetic medication plan, does participation in a holistic care bundle as compared to patients who do not participate in a holistic care bundle result in an increase in anti-diabetic medication plan compliance and achievement of an optimal hemoglobin A1C level range? The goal was to present interventions that can alleviate the factors that patient is facing and allowing them to have better management of their disease. This is a quality improvement project that is designed to implement interventions that most healthcare professionals can use in their practice to aid patients to be more compliant in taking their anti-diabetic medication. Quality improvement is ongoing and will continue to be revised. With the outcome of this quality improvement project, it will lead to policy revision in healthcare practice. By successfully identifying factors that are stopping patients in being non-compliant in their treatment plan and giving proper recommendation for treatment of those factors which are identified. Which brings us to the background of the problem of interest. The rising prescription drug cost has affected millions of working and non-working Americans, and this continues to be an ongoing issue. Interventions need to be implemented that can lower the cost of drugs for patients. Change can be first started at the patient's provider's office. By healthcare professionals providing medication samples and coupons, introducing patients to pharmaceutical assistance programs, or prescribing lower cost drugs to patients according to their insurance plan. Educating the patient about the disease and the need for treatment will allow the patient to be more compliant with controlling their disease. The need for involving lifestyle changes such as exercise, eating healthy, and promoting self-care is a must, and that needs to be encouraged, and access to such things need to be available. Diabetes in general has many related comorbid diseases that patients deal with who have uncontrolled diabetes, such as heart disease, hypertension, hyperlipidemia, and so on. That needs to be identified and addressed by healthcare providers, and proper recommendations need to be given, which is not always done. Nursing plays a big role in treating diabetic patients. Nurses are one of the first person patients encounter and the person who spends the most time taking care of the patient. With that in mind, they have a great deal of idea of how the patient's behavior towards their diagnosis is, patient's thoughts on their treatment plan, patient's motive in being compliant with their treatment plan, their motivation on self-management, and their affordability status on getting their medication. The healthcare professionals, including advanced practice nurses treating patients with diabetes, are the main factors that can change the way treatment is delivered for the better outcome of the patient by catering to the patient's need. With that in mind, they have a big hand in implementing interventions and knowledge that is beneficial for the patient and healthcare overall. The project was conducted in a private practice on type 2 diabetic patients. The practice owner and the manager were in full support of the project and offered financial and administrative backing. All health providers and other medical staffs were supportive and willing to volunteer in conducting this project. Collaborating physician, the director of the endocrine department at the practice, gave guidance in the IRB process. The IRB was obtained from Maryville University. The collaborating physician also gave assistance in general questions pertaining to the project and issues that arise during the project. Benefit to practice. How will this project benefit to practice? It will promote medication adherence and identifying other factors which inhibits patients' noncompliance and suggesting holistic care bundle interventions targeting those factors will increase patients' compliance rate to taking anti-diabetic medication, in turn aid healthcare providers to improve ways to treat patients in daily practice. Most patients with diagnosis of type 2 diabetes fail to achieve an optimal glycemic control. One major cause is poor medication adherence. With poor compliance comes increased comorbid diseases, healthcare costs rises, and mortality and morbidity rates continue to go up. Major factors that promote patients to be non-compliant with taking their medications are out-of-the-pocket cost, health illiteracy, and lack of education of lifestyle and dietary changes needed to achieve better glycemic control. A literature search was implemented for this project. Search engine used was PubMed, Cumulative Index to Nursing, and Allied Health. Keywords were searched for and Boolean operators were used. The abstract of the study was reviewed to find studies that specifically address topics of interest such as type 2 diabetes, medication adherence, lifestyle and dietary changes, self-care management of diabetes, and health literacy. Articles were grouped into themes and narrowed to 13 research articles to review. Some of the topics of review were medication adherence, medication coverage and affordability status, fixed medication regimen, forgetfulness in taking their medication, lack of education on the benefits and side effects of the medication, good communication with healthcare providers, dietary and lifestyle changes, changes in dietary behavior, exercising, stopping unhealthy habits such as smoking, drug and alcohol use, and losing weight, self-care management, and health literacy, lack of knowledge of the disease, low health literacy, lack of motivation for self-care, family and provider support, self-management programs. Some of the strengths that were found during our literature review was that some studies used questionnaires to collect their data, which is inexpensive, practical, and a quick way of getting results and can be analyzed quickly as well. Some studies had big sample size, which would increase the reliability of the results. Weaknesses were that mailing questionnaires were not all received back. Some studies had smaller sample size, which affected the reliability of the results. And some studies were not reviewed by the Research Ethics Committee. Gaps and limitation was race and ethnicity, which was not equally distributed among the subjects. Self-reporting of the subject was unreliable. Most of the studies were cost effective and not cost efficient. The data analyzed by some of the studies was by one researcher, which affects the reliability of the results. theoretical framework used was the change theory. Loon's approach consists of three stages: unfreeze, change, and refreeze. Loon's theory applies to the need for change with both healthcare professionals and diabetic patients' self-reliance and self-care. Applications of the two projects: Loon's change theory provides a framework for promoting individual and organizations to discover and accept that some sort of change may be necessary, considering the possible modification and then implementing the changes in policy and behavior. Which brings us to the methodology part of the project. This is a quality improvement project that was implemented to type 2 diabetic patients in an endocrine clinic in the Northeast region of the United States. The current American Diabetic Association guidelines for the diagnosis and treatment of type 2 diabetes was implemented as part of the quality improvement intervention. At first, the educational intervention was presented to the providers, which includes current American Diabetic Association guidelines for the care of patients with type 2 diabetes. Guidelines on how to diagnose patients with type 2 diabetes, the need of review of medication lists and making adjustments accordingly addresses any issues preventing patients from taking their medication, such as affordability status, side effects, and patients' questions pertaining to the medication, addressing lifestyle and behavioral changes, screening for other comorbid diseases related to diabetes, such as renal, peripheral vascular, and heart disease, encouraging self-care. Second, the practice guidelines with prompts were embedded into the customizable templates in the electronic medical records. Thirdly, education to the provider and the support personnel on how to use and document in the new EMR template was provided. Fourthly, a pamphlet, My Type 2 Diabetes Action Plan, that includes the current ADA guidelines, was distributed to the patient after verbal education was completed by the provider. After implementing the quality improvement project, which was lasted for 5 months, a retrospective chart review was conducted within a 3-month of the intervention. This is a collection of quantitative data using the exploratory design that was collected pre and post intervention. It was anticipated that 70 EMRs would be reviewed for this project. The data extracted from the EMR are from adult patient population comprising of approximately 35% Caucasians and 65% from other ethnic groups. The age of the patient ranged from 18 to 85 years of age. All genders were included in the data collection. The data extracted from the EMRs were from patients with a documented diagnosis of type 2 diabetes who received the quality improvement intervention within a 1-month time frame. The exclusion criteria are that participants had to be between the age of 18 to 85 years of age. The EMR had documentation of the patients having a diagnosis of type 2 diabetes were seen at the clinic from February 16 to April 22nd, 2021. Participated in the intervention, had a follow-up visit 3 months after the intervention. Educational intervention and diabetic recommendations were performed. Type 2 diabetic action plan was given to the patient. Baseline and post follow-up hemoglobin A1C and BMI levels were documented. List of diabetic medications were reviewed, as well as new additions to the treatment plans were documented. Eye, dental, podiatry, and influenza vaccine status pre and post intervention were documented, as well as smoking and exercising status as well. The exclusion criteria includes any patient that was less than 18 years of age. There was no documentation of a diagnosis of type 2 diabetes. Patient was not seen in the clinic between February 16th to April 22nd, 2021. The patient did not appear for a follow-up 3 months after the intervention for a follow-up visit, and there was no baseline or post-intervention A1C or BMI level documented. The data was collected using a data collection sheet. A retrospective chart review was the method of collecting the data. Participants' hemoglobin A1C level, body mass index, smoking status, influenza vaccine, eye, dental, and podiatry status were also obtained pre and post intervention, the status on the subject on getting the educational intervention, and being introduced to the diabetic action plan was also documented on the data collection sheet. According to the ADA guidelines, the hemoglobin A1C is a great indicator of how well diabetes is managed. Obesity seems to be a leading factor that makes the patients more subjective in obtaining diabetes, hence the collection of body mass index pre and post intervention. The intervention addressed weight loss when necessary for a subject that participates in the study. Uncontrolled diabetes tends to affect the eyes, possibly causing retinopathy, macular degeneration, and possibly vision loss, which makes it the most significant issue to address with all diabetic patients. Podiatry exam is always encouraged because diabetes can lead to peripheral vascular disease and lead to pressure ulcers to the lower extremities. Most patients also suffer from retinopathy and tend to lose sensation to the lower extremities, which can make the patient more subjective to burns, injuries, and ulcers. The need to ask patients about burning or tingling and numbness to upper and lower extremity is a must. Examining patients' feet at every follow-up visit is also needed. Smoking is another issue that was addressed. Smoking can make a subject more likely to worsen their diabetes, making the subject to be less insulin sensitive and more likely to develop vascular issues. Vaccination being up to date is also important, especially the yearly flu vaccine. Diabetics are more prone to getting the flu. The project was a quality improvement project that ran 4 to 5 months in duration. It was anticipated that there would be about 70 in-person participants. The budget for the project was created according to expected costs needed to complete the study. Total approximate cost of this project was $299.95. The IRB reviewed the project proposal. There are no anticipated risks to the subject in this retrospective chart review study beyond the minimal risk of breach of confidentiality. A quantitative exploratory design was used and a retrospective chart review was utilized for this project. Convenience sampling was used. It was anticipated that 70 EMRs would be reviewed for this project. The anticipated number of participants were calculated using the power analysis. Scale data that includes the hemoglobin A1C, body mass index, pre and post quality improvement intervention was collected through a retrospective chart review. Besides the scale data collected on pre and post intervention on subject status on smoking, influenza vaccine, eye, podiatry, and exercising and dental was also obtained as nominal data. The Z test was used to compare the data, which allowed to determine if any change occurred between the variables after intervention implementation. Programs used to document and analyze data was Microsoft Excel 2020 and SPSS version 27. Hemoglobin A1C level is a good indicator of how a patient's diabetes is being managed and if any adjustment to treatment plan is needed. The body mass index is a good indicator for the amount of body fat each patient has and if they are at risk of developing diabetes if already not a diabetic. A total of 155 records were abstracted from the EMRs. These records were reflected information for patients with a documented diagnosis of type 2 diabetes who received the quality improvement intervention. The capstone project successfully establishes an improvement in hemoglobin A1C level, body mass index, cessation in smoking, increased compliance with eye and podiatry exam, increase in exercising regimen. Many patients agreed to get the influenza vaccine, but were not available during the time of conduction of the project due to it not being flu season. A paired t-test indicates a statistical significance in decreasing hemoglobin A1C level and body mass index. There is sufficient information to suggest a decrease in hemoglobin A1C level and body mass index from pre and post intervention. The achieved power study is 1, which is considered high in strength and indicates the significance of the results. A Z-test was performed on the data collected on the status of smoking and pre and post intervention. It was noted that an increased percentage of patients stopped smoking post intervention. Exercise status increased in percentage as well as eye and dental exam post-intervention. The confidence interval is a true indication in change in ratio pre and post-intervention. The achieved power is strong for all variables tested, which is a good indication of change in one direction. The podiatry exam status was noted with increase in percentage post-intervention, but was not noted with the expected increase of percentage desired, which is indicated by a low achieved power. The percentage of flu vaccine post and pre-intervention did not change much. Patients' follow-up turnout rate was an issue. Data collected was solely based on healthcare professional documentation pre and post-intervention in patients' charts. Some healthcare providers were reluctant to document all the required information requested on the education intervention. There was a need for a constant reminder for document necessary information addressed to the holistic care intervention after implementing the intervention, which was crucial to the study's results. The study's outcome is essential for necessary frequent educational intervention for healthcare providers treating type 2 diabetic patients. It is set forth the importance of making this educational intervention a vital piece for new healthcare providers, monthly staff meetings, and adopting appropriate communication methods for better management of type 2 diabetic patients. The results justified that the holistic care intervention implemented to patients were effective in improvement of patients' management of their diabetes, which was noted with a decrease in hemoglobin A1C level and body mass index. More patients were compliant with getting their eye, dental, podiatry exam completed, and a huge portion of patients stopped smoking as well. However, the influenza vaccine status was not changed. Vaccines were not available for the patients to get due to it not being flu season during the conduction of the study. Having a healthcare team that is well educated in providing a holistic way of treating diabetic patients can serve as an outlet for support and way of direction for type 2 diabetic patients seeking better management of their disease. The limitations noted, healthcare providers had different attitudes toward implementing holistic care interventions. Providers did not have enough time to document all necessary information in patients' chart between patients. Patients needed more time between their follow-up visits. Influenza vaccine was not offered to the patient due to it not being flu season. Educational sessions appeared to be well received as participants declared that their knowledge in American Diabetes Association guidelines was immensely refined. Despite educational interventions, information was well received. One could not measure the amount of information retained by the healthcare provider and interventions provided to the patient receiving diabetes care. There was no way to verify if the healthcare provider utilized the holistic care intervention presented to them during the educational session in treating their patients. Due to the time restriction that they were already facing seeing patients, it was noted that not all documentations were done within the patient's chart. The re-evaluation of patient status on getting their eye, dental, podiatry, and smoking after holistic care intervention was implemented, a change was noted, and better adherence and recommendation among patients were acknowledged. Hemoglobin A1C level, body mass index was seen to positively improve. However, no significant change was noted in influenza status due to it not being readily available during the project. Much work is needed to manage time and decrease providers' patient load to allow them enough time to treat their patients efficiently while addressing all their issues during a visit. Regardless of the training provided to the healthcare providers by the organization, all participants expressed a positive impact on the knowledge and skills of diabetes assessment and diabetes management in patients receiving treatment for type 2 diabetes. A comprehensive approach needs to be taken in order to care for person living with type 2 diabetes by factoring in their healthcare history, genetic makeup, symptoms, current conditions, social issues, psychosocial issues as well, health illiteracy, economical factors in treating the disease. With healthcare providers having a picture of their patients' needs, then they can manage the disease successfully and incorporate the necessary intervention needed. This project finding suggests a profound need to institute an effective educational tool to support clinicians in diabetes management. The outcome of this project sets forth the need to develop a healthcare policy for improved type 2 diabetic assessment and management in patients receiving treatment. This intervention will help establish a blueprint for developing and integrating holistic care interventions in treating diabetic patients. A patient diagnosed with type 2 diabetes, substandard diabetes management ensues due to insufficient knowledge and lack of holistic way of approaching a treatment plan. Healthcare providers are responsible for asserting that effective diabetes management is provided to patients receiving diabetes care and continually strive to seek education and training crucial to attaining their goals. This quality improvement project furnishes a holistic care intervention on diabetes management to healthcare providers at an endocrine clinic to determine the intervention improved diabetes management among patients receiving diabetes care. All healthcare providers that participate in this study expressed improved confidence in knowledge and skill when initiating diabetes management. It may be of value to provide periodic constructive educational sessions to healthcare providers to continually refresh their knowledge and skills in diabetes management and how to approach holistic way of treatment among these patients. Which brings us to the reference section. I hope everyone enjoyed the presentation. The presentation has brought a light changes needed to better manage diabetes.